Welcome everybody. Let me talk about my PhD projects on hemodynamic management in the perioperative period of non-cardiac surgeries. I am Zsuzsanna Weber. I'm a clinical physician and a PhD student. I work at Semmelweis University, Department of Anesthesiology and Intensive Therapy. My vision is standardized yet personalized patient care worldwide, and my mission is to help create high-quality, evidence-based strategies while being effective in patient care. With the first project, we investigate the safety of continuing renin-angiotensin-aldosterone inhibitors for non-cardiac surgeries by meta-analysis, and the second project investigates the efficacy and safety of multimodal individual hemodynamic management in patients undergoing major abdominal surgery, and this will be a study protocol for a randomized controlled trial. Let me start with the first project. The problem is many patients undergoing major non-cardiac surgeries have hypertension or chronic heart failure, and antihypertensives like angiotensin-converting enzyme inhibitors and ARBs usually play a key role in the treatment of these conditions. And because general anesthetics also have blood pressure lowering effect, we know that continuation of these drugs perioperatively can lead to hypertension and cause deadly complications. On the other hand, discontinuation of these drugs can lead to hypertension, and it is uncertain whether withholding them actually reduces hypertension-associated complications. We are missing strong, consistent guidelines. For example, Japanese guidelines suggest withholding these drugs on the day of surgery. Canadian guidelines suggest withholding them a day before surgery, and ESC guidelines have a different recommendation for patients with or without heart failure. And also, you can see that the class of recommendation level of evidence is quite low in these recommendations. In order to improve them, we would like to investigate whether continuation strategy is the safer approach. The clinical question is if continuation of RASes is the superior strategy for reducing complications in patients undergoing major non-cardiac surgery. RASes refer to ACE inhibitors and ARBs. We use the PICO framework. The population of interest is patients treated with RASes undergoing major non-cardiac surgery. Intervention is continuation, and the comparator is discontinuation of RASes. The primary outcome is mortality, and the secondary outcomes are major adverse cardiac events, hypertension, and acute kidney injury. The hypothesis is that the continuation of RASes is significantly safer than discontinuation. With the preliminary research, we found these 3 key articles that made the project feasible. I would like to highlight that they were all published after the last meta-analysis in the topic came out. We conducted the systematic search on 3 databases using this search key consisted of 3 domains, from which the first refers to the population, the second refers to intervention, and the third to the context of intervention. With the search key, we found 5,099 articles, and we reduced this number to roughly 4,000 with the duplicate removal. You can see the progress of my first project here. As you see, we are almost done with the title and abstract selection. We only have a few maybes left, and we can move on to the next step. Let me introduce the second project about multimodal individual hemodynamic management. The problem is anesthesia is safe, but high-risk surgeries are still associated with postoperative complications. And even though only 10% of the high-risk, 10% of the surgical population is high-risk, that 10% is responsible for over 80% of overall mortality. We know that intraoperative hypoperfusion increases the risk of postoperative complications. Therefore, adequate hemodynamic monitoring is crucial. The most often used monitoring for a standard risk surgery includes heart rate measurements, ECG, non-invasive blood pressure monitoring, and pulse oximetry. This is what we call routine monitoring. For high-risk surgeries, this can be supplemented with the measurement of central venous pressure, invasive blood pressure monitoring, and pulse pressure variability measurement. In such cases, we are talking about advanced hemodynamic monitoring. Multimodal hemodynamic monitoring gives us even more information, such as cardiac output, stroke volume, central venous oxygen saturation, etc. And if we put these parameters in the context of the given patient, given time, we can provide personalized care. The whole purpose of hemodynamic management is to avoid hypoperfusion and keep balance between oxygen delivery and oxygen consumption. In case of individual hemodynamic management, the method for achieving this goal includes putting all these parameters in the context of, again, the given patient, given time. And even though strong pathophysiological rationale supports this method, clinical evidence is lacking. And given that it's a very complex and time-consuming method, its efficacy and safety cannot be guaranteed only based on pathophysiological rationale. In order to clarify whether we need this very promising but also very slippery method, we need to perform a randomized controlled trial, for which the clinical question is if multimodal individual hemodynamic management reduces postoperative complications in high-risk patients. We use the PICO framework again. The population of interest is high-risk patients undergoing elective major abdominal surgery. Intervention is multimodal individual hemodynamic management, and the comparator is conventional care. The outcome is a composite outcome of postoperative complications as defined by a highly impactful paper from Salzwedel. The hypothesis is that multimodal individual hemodynamic management is superior to current standard of care in reducing postoperative complication rates. You can see the feasibility schedule for this project here. As you see, we have adequate material conditions, adequate financial conditions, and human resources, and the other parts of the feasibility schedule is under process. In summary, I would like to finish the first project by September of 2025, and the second by February 2026. Let me finish the presentation with a quote from Erika Badu: "The man that knows something knows that he knows nothing at all." So let's not settle for what we believe to know, but keep on discovering and learning. Thank you for your attention.
You are a really anesthetist, and what is your clinical experience? What is more dangerous, the hypotension or hypertension?
Well, I have very little experience, but I've seen examples for both cases. So, but I would suggest to continue. This is why we chose this.
Well, it's rather a comment or an advice than a question, but I would like to hear your opinion on the second project, major abdominal surgery. This patient, especially if they've been in hospital for quite some time, they can be dehydrated at the time when they come into theater. So how can we be sure that the fluid level preoperatively is the same for all patients?
That's a very good point. I think maybe we can even change protocols and have different recommendations for hydrations or to do a standard how to hydrate patients. And we can do measurement before surgery to know whether they're starting from the same level for the trial.
In the second study, when you're talking about the RCT that you're planning to do, what is your definition for high-risk patients that you're planning to work with?
That's a very good question. Thank you. I was wondering about it a lot, and I would like to. I'm not going to show you. I just tell you that the reference that I used for the background of that project says that high-risk surgical population. That means these are mostly older patients who have comorbidities. They are, according to the OSA score system, at least 2 or 3 or worse, and also that major surgery. So it's not enough to have comorbidities and be old. You also have to go under major surgeries.